Hello and welcome to the Royal College of Pathologists Guideline Implementation Webinar Programme. My name is Peter Johnston and I'm the Vice President for Workforce and Corporate Engagement at the College. I'm delighted to be hosting the webinar today where we have leading experts and authors of the updated guidelines on the dataset for histopathological reporting of carcinomas and mucinous neoplasms of the appendix. The authors will be presenting the highlights of the guidelines and also mentioning some aspects which may be difficult to implement, and they'll offer some practical tips and guidelines around about how to implement the data set. They'll also be here to answer your questions. I'm pleased to introduce to you today's speakers and authors of the data set. They are Dr. Manuel Rodriguez-Justo, Professor Norman Carr, Dr. Newton Wong, and Professor Roger Feekins. Before we start the webinar, just remind you that the webinar presentation will take approximately 15 minutes and will be followed by around 20 minutes of questions and answers. All participants will remain muted throughout, and if you want to ask a question, please do so using the Q&A button at the bottom right-hand side of your screen. We will then convey those questions to the authors who will address them. So without any further ado, thank you both and thank you all for coming, and over to you, Manuel, to start the presentation.
What we are going to talk about today is the appendiceal mucinous neoplasia, and this is just a very brief, comments about, they are not very frequent, so just less than 1% of the appendicectomy specimens, a little bit more common in the females. We will cover that later. The prognosis depends on the type of the tumor, the staging, the grading, and the surveillance, the survival depends, varies between the type of tumor between 10 and 90%. The symptoms, everyone knows that. So sometimes it's just something like appendicitis. Very common, we have mucinous ascites and very non-specific symptoms like weight loss and abdominal pain. And again, everyone knows that whenever you have a metastatic tumor in the appendix, the treatment is either cytoreductive surgery, and this is combined with HIPEC. So this is a very busy slide, and we will cover that in the next 10 minutes. So what we are talking about today is this appendiceal mucinous neoplasia. Like this one, you have this big appendix here, very dilated. The second one on the bottom looks more tumoral. And we are going to talk about low-grade appendiceal mucinous neoplasia. And in terms of what diagnostic criteria we use in terms of the invasive margin is pushing rather than invasive, whether we have a rupture of the appendix, whether we have mucin outside of the appendix. There are low grade in cytology. The high grade of the HAMD is exactly the same, but the cytology of the epithelial dysplasia is much more high grade. The mucinous adenocarcinoma, very similar to the colorectal. You have more than 50% of the tumor has to be composed of extracellular mucin, and we have mucinous adenocarcinomas with signet ring cells. Less than 50% of the tumor component is signet ring cells, or more than 50%, and we call that just a signet ring cell carcinoma. So just to make a comment about, because we are going to see that very often, what is the difference between just a standard adenoma in the appendix, colorectal type, or a LAM, a low-grade appendiceal mucinous neoplasia. And you can see in terms of the cytology, it's going to be very similar. The LAM means usually they lost the muscularis mucosae, or at least this is very attenuated. In the appendiceal adenomas, the muscularis mucosae is intact, and the LAM means you can have extension of the mucin, either epithelial or just mucin through the wall, and in the adenomas, this is just confined to the lumen. So this is a summary of what I have mentioned just right now. The low-grade appendiceal mucinous neoplasia, so the margin is invasive, the cytology is low-grade, so it's grade 1. The high-grade appendiceal mucinous neoplasia, what we call the HAMDs, so the margin is again pushing, but the cytology is high-grade, grade 2. The mucinous adenocarcinomas could be either sometimes more infiltrative, sometimes more pushing, and again, in terms of the any cytology, could be low, high-grade, and the mucinous adenocarcinomas adenocarcinomas, they are usually very infiltrative, and they have signet ring cells, either in mucin pools or just signet ring cells infiltrating the tumor. And just remember that at least you need 10% to call something with adenocarcinoma with signet ring cells, and if you have more than 50% of signet ring cells, we call that signet ring cell adenocarcinoma. And these are just a few examples. So starting from the left-hand side, the typical laminin is confined to the wall, is a little bit villiform epithelium, but if you look at the cytology, it's very low grade. You can see it's a single layer of the cells. The hams, very similar to the laminin, but the cytology is much more atypical. So this is a high grade, like any other GI tract. The mucinous adenocarcinoma, like any other mucinous adenocarcinoma, with lots of extracellular mucin. And again, whenever you have signet ring cells, either whether it's more than 10% signet ring cells, so we call that mucinous adenocarcinoma with signet ring cells. But if you have more than 50%, like in here in the top right, this is going to be a signet ring cell carcinoma. You can have non-mucinous adenocarcinomas, and again, this is similar to the GI tract, whether we just combine them in low grade or high grade. So the low grade is what we used to call low to moderately differentiated, and the high grade is just a poorly differentiated. Just a quick slide about serrated lesion in the appendix. We can see that, and there are just precursor lesions for some of these mucinous adenocarcinomas. The WHO recognized these ones. There's a serrated lesion without dysplasia, and the serrated dysplasia low grade or high grade. Just to mention in terms of the molecular, already we will cover that later, that usually everyone knows that the mucinous or the serrated pathway, usually you have more BRAF mutations than KRAS, but in the appendix it's unusual because even the serrated lesions, they have KRAS mutations and no BRAF mutations. Just again to define what we are talking about, different terminology, Pseudomyxoma peritonei. So this is a clinical syndrome, it's not a disease itself. And what you have here is lots of mucin in the abdomen. Ascites is a mucinous ascites. Very common, you have this omental caking, and you have here one of the pictures with this omentum with lots of these white nodules. And whenever you have pseudomyxoma, the appendix is usually 90% of the cases the primary site, but remember that you can have pseudomyxoma coming from the ovary, the pancreas, the colon, and even sometimes from the upper GI. The grading of the pseudomyxoma is slightly different than the appendix. You can have only a cellular mucin. You can have low-grade mucinous adenocarcinoma, is what we call grade 1, high-grade, grade 2, or you can have whenever you have lots of mucin with signet ring cells, that's a grade 3. And it's not uncommon, it's not very rare, but it's not uncommon that you can have this discrepancy between the primary and the cytology in the pseudomyxoma. And this is very important to know, because the most important thing is the degree of the atypia of the cytology in the pseudomyxoma, because this is going to dictate the prognosis. And what we have included in the guidelines is that you have to grade separately what is the grading in the primary, in the appendix, and what is the grading in the pseudomyxoma. So just moving on to the primary tumor, the TNM, and this is the T. And again, everyone knows that, and that's in the classification. And this is just a little bit more clear. So for adenocarcinomas and for HAMs, we have the PT1, like any other organ in the submucosa. The PT2 is whether the tumor involves the muscularis propria. PT3 is going into the subserosa. And whether you have serosal involvement or perforation, this is a PT4A. The only difference here is for the lungs, whenever you just have is confined just to the mucosa or the submucosa, the muscularis, we don't use the PT1 or the PT2. For the lungs with no mucin dissecting the wall or anywhere else, we call that a PTIS. That's the only difference for the low-grade appendiceal mucinous neoplasia. And these are just a few examples. So just remember, even whenever you have, if you have a cellular mucin and that's going into the subserosa or is breaching the serosa, even if this is low grade, it's PT3 or PT4. But again, just remember, if this is just only a little bit of mucin in the muscularis mucosa or in the muscularis propria or in the submucosa, it still is a PTIS. And this is a typical example here in the bottom left, where you have, a clear laminin here, and you have extracellular mucin, and this is going into the subserosa or the serosa. So this is going to be a PT3 and a PT4. And the other thing you have to remember, even when you have a tumor cells in addition to the mucin, it's very important to record that in the guidelines, because the prognosis is going to be worse whether you have tumor cells in addition to the mucin. In terms of the lymph nodes, it's very similar to the lower GI. So we have the lymph nodes, the 1A, the 1B, and the 1C. But with the more than 4 lymph nodes, we don't differentiate it whether it's PT2A or PT2B. The issue about the tumor deposits is still very controversial, because there is not much data. We still use the same thing like in the lower GI. So if you have tumor deposits, this is going to be the 1C, but sometimes, it's very difficult, particularly when you have pseudomyxoma, because by definition, this is going to be just peritoneal disease. In terms of the metastasis could be just a cellular mucin, or could be epithelial cells as well. And that's slightly different to the colorectal. So if you only have a cellular mucin, this is going to be an M1A. If you have mucinous epithelium, it's going to be M1B. And when you have non-peritoneal metastasis, and I'll show you that in a minute, that's going to be M1C. And these are just a couple of examples. So the N1B includes whenever you have serosal deposits, whether it's in the ovary, or I put you here one of the examples with a just tumor over the surface of the spleen. And here the histology, you have an extracapsular tumor deposit. So this is N1B. Whenever the tumor is non-peritonealized, so it's just inside the organ, and because this could be just hematogenous or non-regional lymph node metastasis, this is what we call an N1C. So what is non-core items but might be important? I think in these cases we don't need to do any immunohistochemistry, but if you have to, it's the typical CK20 positive, the CK7 usually negative but can be patchy, and the MAC5A is positive in most of the cases. Again, it's not a non-core item, but the MMR is usually recommendable to do that. Usually these tumors that are deficient. And in terms of the molecular, I think we have included in guidelines, as a non-core item, KRAS and BRAF. And KRAS is always the most frequent one. But again, the oncologists at the moment that don't use that in terms of the treatment is mainly the stage and the grade and everything else. A couple of slides about potential pitfalls. So just remember these pseudo-signet ring cells. So here on the right side, you have the typical signet ring cell morphology, and it's not very rare, like in the gastric carcinomas, that you have these degenerated epithelial cells or macrophages that look like signet ring cells, but they are not signet ring cells. And again, you can see that with the morphology, whether you do mucin stains or proliferation markers, but just be aware that sometimes they are very tricky to differentiate these pseudo-signet ring cells. Another mimickers of the lamins, everyone knows that verticular disease, again, it's very low-grade morphology. In general, you have a little bit of lamina propria that's preserved. And the other thing, just remember, again, and we have seen a few cases, this endometriosis with intestinal metaplasia, they look like lamin, and what you have to look at is, this endometrial stroma, either with just a standard H&E or with a CD10. And the other thing we are not going to cover today, and that's because it's a different guidelines, is whenever you have lots and lots of goblet cells, just think of signet ring cells, think that this could be a goblet cell adenocarcinoma rather than a lamin or a appendiceal mucinous neoplasia. And I think that's the last slide. Yeah.
So thank you very much for that. I'm sure there are some questions coming through, and I've got some interesting things to ask you. Before we go to the questions, just briefly, Norman, you were going to say a few words about the new WHO classification as regards appendiceal neoplasms. I think now would be an appropriate moment for you to do that, if you would, please.
Yes, of course. In the 6th edition of the WHO classification blue books, it should be coming out, we hope, later this year, but sometimes it can be delayed. We are going, or there will be introduced a new use of the term appendiceal mucinous adenoma for things we would now call LAMN, that are at the very benign end of the spectrum. It's becoming increasingly clear with every study, every case series that's being published, that unruptured LAMNs, with no evidence of pushing into the wall of the appendix, have a very, very low risk of subsequently developing pseudomyxoma peritoneal. So, for these very, very sort of benign looking lesions, we're going to reintroduce the term appendiceal mucinous adenoma. And the definition is this: appendiceal mucinous adenoma is characterized by a circumferential proliferation of neoplastic mucinous epithelial cells confined to the mucosa with an intact muscularis mucosae. So the diagnoses of LAMN will still be valid, and colorectal type adenomas, look like tubular or tubular-villous adenomas, they will still be valid, but this will be an additional diagnosis to consider. And the implication will be that complete excision should be curative.
Thank you very much. If I may just comment at this stage, it seems to me that the classification is really quite complicated. Today we've spoken about lesions, polyps, adenomas, neoplasms. How do we get our heads round about this? Because they are clearly, from what you say, distinct entities. So is there an easy way of trying to remember how they all fit together and which one is which? Because it's just on the face of it quite confusing.
Well, I think there is, in the terms that everyone is quite familiarized with the low-grade appendiceal tumors, mucinous neoplasia. So you can have, serrated lesions in the appendix, like in the lower GI, and they look exactly the same. You can have adenomas, like the colorectal, they look the same. So I don't think we are different in that. The low grades, everyone recognizes that. The thing that people find a little more difficult is the high grades, the mucinous neoplasias, and the HAM, and there are all these funny names. The mucinous adenocarcinoma, again, is any other GI organ, and the signal ring cells. So I think we use exactly the same terminology. I think the difference and why people get confused is with the lamins and the hams, and particularly with the T stage and the mucin and all these sort of things. But yeah, I think it's quite intuitive, most of the lesions.
Good. Just there's quite a few questions about that terminology and exactly which one goes where, but presumably the guidelines state these things quite clearly, which will be very helpful. Just also asking about the presence of the genetic abnormalities. We've again heard about KRAS and BRAF particularly, but there is a question about whether the serrated polyps are different from the sessile serrated lesions in the appendix, and if so, why so?
Yeah, so I think Norma can comment on that, but the thing is, in the appendix, although I say, it's SSL, so we call it still serrated, so sessile serrated polyps rather than SSLs in the appendix. But, everyone knows about the serrated pathway in the lower GI, and they are mainly related to the BRAF mutations, and in the appendix is different, it's the KRAS pathway. But again, there is no matching data because, these tumors, they are not very, very common. So
Yeah.
Norman, what are your views about the serrated?
I agree. I think that sessile serrated lesions in the appendix, they look essentially the same as their colorectal counterparts, but genetically they're different. And of course, their implication is different too. Sessile serrated pathway in the colon does not lead to the mucinous type lesions that you see in the appendix, and vice versa. I was very keen on the idea of not calling them sessile serrated lesions for that reason, and just calling them serrated polyps, which is a non-committal term until we got to know more about them. However, this has not caught on, so I've given up now, and I'm calling them sessile serrated lesions as well, but we have to know in our hearts that they are not the same as the ones you see in the colon. And this is because the appendix is different from the colon. And that's one of the reasons that we have things like lambs and hams that, can be confusing if you don't see many of them. But we have to have these names because the appendix is different.
Okay. Just moving the discussion on a bit, there's a question about risks. You mentioned already about low risk, Norman, in some of these lesions, but this question is about asking progression to metastatic disease and pseudomyxoma peritonei. Are there any comments about how the risk stratification changes in the new classification or in the new guidelines? I don't know which of you wants to pick that up.
Well, I can say that the risk will essentially the risk of a true LAMN that has ruptured will remain the same. If there are cells outside, and if you have a ruptured LAMN with cells outside the appendix, the risk of synchronous pseudomyxoma peritonei is about 40%. And even if there's no evidence of pseudomyxoma peritonei at the time of presentation, there will be a significant risk in the future. So those patients definitely need to be followed up. The risk is less if there aren't any cells, but it is still significant. If the thing is unruptured, the risk is very, very low. And so that's not really going to change with the new terminology, because the new terminology actually is just reflecting the fact that if you have an LAMN, what we would now call an LAMN, that is confined to the mucosa, and there's no evidence of pushing into the underlying wall because the muscularis mucosa is intact all the way around. I mean, these things, as I say, they just don't cause any future problems if you made a diagnosis properly.
Yeah, okay.
That answers the question.
Yeah, thank you. That's helpful because there is another question just about that particular topic. And so you don't see a stromal response to these pushing edges if they don't breach the muscularis mucosae. Is that correct?
That is correct. If they if you see the dense fibrosis underneath the appendiceal epithelium, with no evidence of an intact muscularis mucosae, then I would carry on calling that LAMN. Absolutely. I mean, and if it's unruptured, the risk will still be very low, but you can't entirely exclude it because there may be a previous rupture that has healed and that you can't see. It doesn't happen very often, but I've seen this a couple of times in my career that that when you look at the appendix, you can see, oh, that might have been an area of rupture. And it probably was because the patient has since gone on to develop pseudomyxoma, but it is rare.
Thank you. I'd just like to move on to talk about staging for a minute, about malignant lesions, clearly, because there's a few questions around about that. So in terms of lymph node sampling, what are the recommendations about lymph node sampling for carcinomas? Are they the same as other colon cancers, or are they different for the appendix, given what you've just said?
I don't think we have any recommendations clearly in the guidelines, Newton or Norman. Did we say anything about numbers, particularly for appendicectomies? The specimen is very difficult. But
yeah, that's fair dues, especially if it just comes as the appendix. Sorry, Norman, go on.
Sorry, I mean that's right. There have been a few recent papers suggesting that if you have a right hemicolectomy, the more lymph nodes you find, the better. Just the same as in the colon. Yeah. I don't think we actually specifically state anything except to say, I suppose off the top of my head, that if you're going to use guidelines and it's a right hemicolectomy, why not use the same ones as in the colon? Just because we have nothing better to go on. And if you have only an appendicectomy, you may find a lymph node, even two lymph nodes in the mesoappendix. So it's worth having a look.
Yeah, and so the other question about those lymph nodes specifically is, if we see mucin in a lymph node, is that sufficient to say there's metastatic disease, or do we need to see the cells producing that mucus?
I think it's the same thing as the lower GI. So if this is chemo-naive, so if you have mucin, of course, if this is has been treated before, no, but it depends whether it's any neoadjuvant treatment or not.
Okay. But most of these patients probably wouldn't have had any treatment, I guess, for getting the appendix. Which somebody's also asking about the presence of a mucinous adenoma or mucinous epithelium at the margin, neoplastic epithelium at the margin of a mucinous adenoma. Again, it's about excision and how you deal with that. And the question that comes from that, I suppose, is do we then recommend that you go for a hemicolectomy after that? Is that part of our recommendations for these tumours?
Norman, you have more experience?
I can answer that because having worked at Basingstoke for many years, if you have an incompletely excised lamum, they will usually go back and not do a full right hemicolectomy, but they'll do an excision of the cecal pole, which is something that I've forgotten the exact name of the operation, but you just take out the cecal pole and that will do. Because usually you don't find anything, and even if you do, that is usually completely excised, and we haven't had any, as far as I know, any problems. Other people say you may not even need to do that and just follow the patients with colonoscopy. So if it's a lamb and it's incompletely excised, I would do no more than just take out the pole of the cecum. But if you don't do that, it's worth following the patient anyway.
Sure, just useful to have that information. Thank you. Again, about staging, there's a question here which is about serrated lesions of the appendix with evidence of rupture. Should this be treated as a PT4A lam, or because we can't entirely exclude it? So we can't entirely exclude that it's an LAMN, but if there's no evidence, if there is evidence of rupture, how do we stratify that? Newton? I'm sorry, you're muted too. Could someone in the team sort the muting, please? There's no muted button on you, but we're not getting any noise from you. Would somebody else like to pick that question up in the meantime? Manuel?
I can. What was the question again? I was trying.
It's about how would we advise that
that's right. A ruptured thing that you think it looks like a sessile serrated lesion, but it's ruptured. I would always look very, very carefully at it before I diagnose it as that. It is possible the patient may have appendicitis, an incidental sessile serrated lesion, and rupture that has occurred due to the appendicitis. Maybe that's all it is. The trouble is, I would always be afraid of being sued, I'm afraid, by getting it wrong. So I would probably err on the side of caution if there was doubt, and tend to have a low threshold for calling it LAMN.
Just before we started, Manuel and I were having a conversation about Pseudomyxoma peritonei, and somebody's asking a question here about mucinous epithelium, bland mucinous epithelium in peritoneal biopsies. How specific can you be over potential primaries?
Well, I think you need a radiology, definitely. I think, most of these ones, they are coming from the appendix, but of course you can have different primaries. And at least in our experience, whenever you have a pseudomyxoma, the radiologists, they can see a mass in the ovary and the appendix, or the appendix looks normal. I think the immunohistochemistry sometimes helps you, but it's going to be the clinical context. And the appendix usually is the most frequent one.
Yeah. Okay. Thank you very much. Again, we've got some more questions about staging of the lesions. But before we go there, can we talk a bit more about the molecular pathology of these lesions, please? Mucinous neoplasms of the appendix are not really Lynch syndrome associated tumors, says one questioner, unlike colorectal adenomas and carcinomas. But MMR might be needed for oncological treatment of the appendiceal cancers. So how do we approach that? And what is the correct way of thinking of this?
So I think we had a lot of discussing about this with the guidelines, and to be honest, my opinion is because the MMR has become very important in terms of the immunotherapy and everything in every single solid cancer. So if you can do it up front, just do it up front. I don't think we need to wait for the oncologist or anyone to do it. As Norman has said, the evidence, whether it's that important or it's very frequent, is less than in the colorectal. But I think you just do it up front. And the molecular is very similar. Some of the oncologists, they are not going to need that in terms of the treatment, but if you have that information, it's even better. And we know that some of the KRAS mutations nowadays, they are actionable. So That's also important.
Okay, thanks. Can we go back to the can we go back to the adenoma and the newly introduced adenoma that you mentioned, Norman, and questions about how we distinguish these again. It's just clarification or restatement, I think, of what you've said already. But as I mentioned, these lesions seem to merge together to some extent. So how can we split them out nicely?
Right. As I say, this is just I'm just warning you what is likely to occur. At the moment, if you see anything that looks like an LAMN, you call it an LAMN. The point is that if you see an undulating, so in the future, if you see undulating or flat pattern with perhaps with filiform villi, the very tall, thin villi with narrow necks that are characteristic of LAMN, but it's obviously confined to the mucosa, the whole thing, and there's no evidence of rupture, then you can call that a mucinous adenoma of the appendix. And the reason we've used to do that is because you're not calling it a low-grade appendiceal mucinous neoplasm, which in theory carries a risk of Pseudomyxoma peritonei. The Americans in particular have been very keen to introduce this terminology, because if you call something an adenoma, it probably is not going to affect your insurance. If you call something an LAMN, even if it's completely excised, you may have difficulty getting insurance, health insurance. So these nomenclature changes, they may seem pedantic, but actually they do have a significance. They do have a reason behind them. And as I say, as far as I'm concerned, if you call something an adenoma in the GI tract, it should imply something that is essentially benign. It might be pre-malignant, but it is benign. And so I think that the use of that sort of terminology in those circumstances is helpful.
That's very helpful to clarify that. Thank you very much. There's another question about peritoneal disease. And when we've got peritoneal metastatic disease, do we grade that as 1, 2, and 1, 2, 3, or high grade, low grade, or as mucinous carcinoma peritonei? And again, the grading system for that was different because you had G1, 2, 3 in that, did you not? So how do we apply that? Do we use the same terminology for metastases as for the primary lesion, or how do we do that?
As we said, we use different grading in terms of the cytology pictures in the metastasis with the peritoneal pseudomyxoma and the primary. And we use the G1, G2, and the G3 or the pseudomyxomas when you have the signet-ring cells, definitely. I don't know if that answered your question.
The other thing to say is that the term mucinous carcinoma peritonei is an alternative name for Pseudomyxoma peritonei. A lot of people don't like using the term Pseudomyxoma peritonei as a histological diagnosis because it is a clinical syndrome. And the term mucinous carcinoma peritonei is used by a lot of people as a synonym for Pseudomyxoma peritonei when they are reporting histology. I mean, I used to do that at Basingstoke, for example, and it's in the guidelines and the WHO and whatnot. But again, this has not been universally picked up all over the place. So, ironically, the term Pseudomyxoma peritonei is the term that no one likes but refuses to go away.
Right. So, in terms of the classification and the application of this, it seems that we've moved forward, but what we're trying to do is to use the terminology to clarify where we actually are with these lesions and to recognize their behavior and how they go forward. So I think that's been helpful to clarify that in the way you have. Further questions we're getting, again, this is about how we use the staging codes in relation to mucinous tumors and mucin itself. So if we've got mucin on the surface of an appendix or away from the appendix, how do we classify that as P1MA, or do we how do we classify then when we've got mucinous, how does that differ from the classification of perforated mucinous carcinomas, not otherwise specified, as it were? So specific questions around about how we use these terms.
So if you have mucin over the serosa of the appendix, whether it's a lamb or a ham, you have to call that PT4A because it's over the serosa. If you have mucin in the abdomen, whether it's peritoneal metastasis, that's going to be a PIM1A or B if you have that in the serosa of the spleen or any other organ. But if this is mucin of the serosa of the appendix, it's a PT4A.
Okay, just something that came up in the questions which I hadn't really thought about before, but I think I know the answer to this. But the question was, do you get or can you get Pseudomyxoma peritonei in relation to a ruptured diverticulum? You're shaking your head, Norman. That's what I thought too. Because my experience.
So I'll unmute myself. No, ruptured diverticular. Do not cause Pseudomyxoma peritonei. It is completely benign. It's not neoplastic. The trick is to get the diagnosis right.
Yeah. I think that's useful because in my mind, you're more likely to get an appendix, get an abscess around about a perforated diverticulum to get mucin all over the shop. But it's interesting. I'm glad you've said that. Thank you.
Yeah. And you can see, as you say, you can see a lot of mucin around a ruptured diverticulum, even though it's not neoplastic.
Yeah. So again, looking through the questions, I think we've kind of addressed most of the issues that have come up. So I just put it out to the audience to come up with any more that they would like to come with. In the meantime, are there any things that you would like to bring out and clarify that you feel, having listened to the questions and the discussion, at any points you'd like to bring, to the discussion at this stage?
There was one question, Peter, I think in the Q&A, that's saying about the muscularis mucosa in the, just in the lambs to differentiate that from an adenoma. And we have also always used that, but that you need, in the lambs, the muscularis mucosa disappears, but sometimes it's still there. It's attenuated, but it's still there. So, it's a very good diagnostic criteria, but you can have a little bit of muscularis mucosa in the low-grade appendiceal neoplasias.
Yeah, thank you. And Newton, let's try and see if we get noise from you this time. Still no noise. I'm so sorry. Do you want to put a comment in the Q&A and we can have a look at it? So there is a question, is Pseudomyxoma peritonei only for LAMN? And the answer to that is no. It's a much more widespread condition that can arise from a variety of different things, can't it? Most commonly, it's appendiceal. So just while we're waiting for Newton, at the meantime, I mean, we've talked about the staging of cellular mucin in the serosal surface, which we were just talking about there. So I hope that's clarified that particular question. So in terms of the disease process in general, I think you said earlier, Manuel, that the lesion was becoming more, or appendiceal neoplasms are becoming more common. Is that connected by age and demographics, or why do we think that's happening?
I don't know, to be honest, but we are seeing quite a lot of these indolent lesions, completely unexpected in young female, whenever you have, an MRI or something for a completely different reason. But, Norman might know a little bit better why they are increasing.
Yes, I can partly answer that. Some people think that it may have something to do with increasing recognition of these lesions and better classification, and that may be part of the picture. But also, studies have suggested that there is a genuine increase, matched for age and sex and all the rest of it, of these lesions. Why? I don't know. It just shows you what a fascinating organ the appendix is.
Yes, much underestimated, isn't it?
I agree.
Yeah, the common stuff, or common sites come with all sorts of entertainment, don't they? I mean, just other questions about Pseudomyxoma generally, and mucinous neoplasms, ovarian teratomas. I mean, I have a case just now which probably relates to it was a cytological presentation, probably relates to a mucinous ovarian, borderline ovarian tumor. But I don't know if you would call that Pseudomyxoma, because we got it as a cytological presentation with mucus floating around in the peritoneal fluid. But what other causes are there?
With the ovary, you've got to be careful because, as I say, if it's a regular ovarian mucinous tumor, like in a borderline cystadenoma, it will spread to the peritoneum. It might need treating with cytoreductive surgery and HIPEC, but it won't give you the clinical syndrome of pseudomyxoma peritonei. The ones of the ovary that do that are the ones that have arisen in a teratoma. And if it's come from a teratoma, those cells, they think they've come from the appendix because they're, it's a teratoma that has given rise to them, not an ovary. So I would always tend to avoid the use of the term pseudomyxoma peritonei from an ovarian lesion for that reason, because it may confuse people and they think and they get the wrong end of the stick. Does that answer? Is that what you mean, really?
Yeah, it does. That's perfect. Thank you. I'll just give the last word to Newton, who's come with a thing on the chat, which he says ultimately we work towards what happens after the appendicectomy. So if it's not LAMN, discharge the patient. If it's LAMN and not ruptured, the new adenoma that we've described, the scope the rest of the large bowel only, so endoscopic follow-up. If LAMN with PT4, then refer to the nearest peritoneal centre, for example, Basingstoke if you're in the southeast of England. So I think very helpful step-by-step route march through that. So thank you very much for your comment, Newton, and sorry that you've had to take the long way around getting it to us. Looking at the clock, I'm afraid that that's all we have time for today. So I'd just like participants, please, to be aware of the fact that the webinar will become available on the college website in a few days once it's been edited, and it will be placed there as a resource for members and fellows to use to help support with the implementation of the guidelines that we've discussed. So if any of your colleagues haven't been able to be with us today but would like to look at it, it will be available on the website in due course. The professional guidelines team at the college will also be sending around a brief questionnaire to provide feedback, and so we'd love to hear from you what you thought of the webinar today. That leaves me just to thank Manuel, Norman, Newton and Roger for sharing the expertise. We all really don't understand, I don't think, the amount of work that goes into writing these guidelines, huge amount of research, then writing it, rewriting it, drafting it, redrafting it, finding illustrations, doing all these things takes a huge amount of effort. So thank you all for all the work behind that and for the very informative way in which you've presented today's webinar. So finally, for participants, don't forget to look at the webinar page for future up and coming webinars related to this program. In the meantime, thank you all, have a great day and goodbye.